My name is Mia Kanak, and I'm a pediatric emergency medicine fellow at Children's Hospital Los Angeles. My colleagues and I are excited to present our work titled Mobile Social Screening and Referral Intervention in a Pediatric Emergency Department. The background of our project is that prior studies have found many families in pediatric emergency departments to have unmet social needs, which may be detected and addressed with the use of electronic screening. The objective of our study was to characterize the effectiveness of a mobile screening and referral app called Help Steps and to assess its impact on clinical flow in a pediatric emergency department. For methods, we conducted a prospective trial with a convenient sample of adult caregivers and patients in the Boston Children's Hospital Emergency Department. Participants were given the choice to either use Help Steps on their personal phone or an ED tablet. Zooming in to show you what the app looks like, the app first screened for social needs across 5 domains: food, housing, transportation, utilities, and interpersonal violence, using the CMS Accountable Health Communities Health-Related Social Needs Screening Tool. Then, participants had the option to self-select a referral from 21 need categories, as shown here on the left side of your screen. The selection then prompted a list of social service agencies based on geographic proximity, shown here in the middle, that the participants could then click on to learn more about and receive information about via text, email, or printed handout. Participants then completed a 1-month follow-up survey. And additionally, on the day of enrollment, clinicians were surveyed about family needs and the impact on ED length of stay. Moving on to results, of 258 participants, 85% were female and the median age was 37. 18% of participants self-identified as Hispanic and 15% as Black. 56%, or the majority, elected to use Help Steps on their personal phone. 88% of participants agreed that screening in the pediatric emergency department is appropriate, but only 10% were screened for social needs by their clinician during that visit. 95% of clinicians reported the intervention added no additional time to their clinical visit. Now I'd like to focus your attention to Figure 1, which shows a comparison of needs identified by a positive screen versus by self-selected referral. Zooming into these overlapping circles, the purple circle represents participants who both screen positive and self-selected referrals for food, housing, transportation, utilities, and/or interpersonal violence. The blue portion represents participants who screened positive but did not self-select a referral, and the red portion represents participants who screened negative but did self-select a referral. For example, looking here at the circle on your left for overall need, 54% of our participants were found to have social needs. 31% of participants both screened positive and self-selected a need. 16% screened positive but did not self-select a need, and 8% screened negative but did self-select a need. Looking across at the 5 additional circles, which each represent a domain of need, the lack of, quote, purple overlap highlights discrepancies between screen needs and self-selected needs. Moving on to Figure 2, which highlights the effect of our Help Steps intervention at 1 month. 79% of participants who self-selected social needs were reached for follow-up, of which 44% reported their top need was completely or somewhat resolved. Of those, 77% reported that Help Steps was useful in finding a solution to their need. In conclusion, mobile social screening was both well-received and effective at identifying and referring families for social needs with minimal impact on ED clinical flow. A majority of families elected to use their personal phones, but the availability of a tablet improved screening rates. Last but not least, our experience found that a screening tool may fail to identify desired social services, and thus an option to self-select referrals may maximize referral opportunities. Thank you so much for your time. I'm looking forward to hearing your feedback and answering any questions.
Hi, my name is Mackenzie Eakin, and I'm a medical student at the Stanford University School of Medicine. I'm presenting the epidemiology of homelessness in one California hospital before and after the Homeless Discharge Senate Bill, also known as Senate Bill or SB 1152. As an introduction, the bill was passed in 2018, originally born out of concern for so-called patient dumping, refusal of care or inappropriate transfer of a patient by a hospital or emergency department due to the patient's inability to pay. The bill's final version mandates all non-state operated hospitals meet and document specific criteria when discharging patients identified as experiencing homelessness. Example criteria include that these patients are offered a meal, weather appropriate clothing, referral to a homeless shelter, assistance enrolling in qualifying health insurance, etc. before discharge. We wanted to observe our suburban academic hospitals' emergency departments' compliance of SB 1152 and to characterize visits by identified patients pre and post implementation of the bill's requirements. To do this, we analyzed EMR data 1 year pre and post for visit demographics and primary diagnoses. Our annual ED volume was approximately equal in both periods, about 77,000 total visits. In the year pre-implementation, we identified patients experiencing homelessness using address data recorded at the point of registration or a coded diagnosis of homelessness. In the year post-implementation, we used either of these or the presence of a discharge checklist in the patient's chart, and any condition was sufficient. As shown in the table on the left, we found that total identified visits by this population increased by about 2.5-fold in the post-implementation year, from 630 to 1530. In both years, the majority of these visits were by patients 18 to 65 years old, and fewer than 10 patients under 18 were identified in either year. In both years, the majority of visits were by men, and although the largest percentage of visits was by white patients in both years, we saw a substantial increase in identified visits by Black patients in the post year, as well as smaller increases by Hispanic, Latinx, and Asian patients. The vast majority of identified visits were by patients who spoke English, and that proportion increased in the post year from 84 to 90%. Lastly, we saw a higher frequency of repeat visits, with 56% of total visits in the post year attributable to patients with at least 4 ED visits in that year. We also looked at the number of unique patients experiencing homelessness and saw a more than 2-fold increase in the post year, from 290 to 691. The most prevalent primary diagnoses were mostly similar across the 2 years, with the 3 most common being alcohol intoxication, chest pain, and convulsions, though we noted an almost 37% increase in the frequency of alcohol misuse diagnosis as the primary diagnosis in the post year. The primary diagnosis of suicidal ideation also notably increased from 1.3 to 2.2%. Finally, we saw that checklists were completed for 92% of ED discharges of identified patients experiencing homelessness, and that in the post year, 41% of those patients were identified only by our check for the presence of a discharge checklist in their chart, not by any of the other pre-implementation identification methods. So in conclusion, identification of patients experiencing homelessness increased after implementation of the discharge checklist. There were notable demographic and utilization differences in identified patients in the pre and post years, but similar patterns of primary diagnosis. And our emergency department appears compliant with SB 1152. Some important limitations to note are that, first, as evidenced, for example, by the near absence of identified pediatric patients, we're clearly still not capturing the entirety of the relevant population, possibly leading to undercounting. Second, once a patient was identified on any one visit in the study period, all of their other visits counted toward unique visits, regardless of potential changes in screening results, which may have resulted in overcounting. And of course, COVID-19 may have affected visit volumes and diagnoses for the ED overall, and specific to this population, particularly in the latter part of the post year. Our hope is that further study will help us better understand the impact of COVID-19 on these findings and lead to better insights regarding this population as a whole, and especially our high-frequency visitors. Thank you.
The COVID-19 pandemic was a challenging time for providers and patients alike, but it showcased the adaptability, innovation, and resilience that drives medicine forward. During the peak of COVID in March and April of 2020, the Mount Sinai Health System in New York City quickly increased utilization of our virtual care platform, Mount Sinai Now, and was able to reach thousands of New Yorkers to provide medical care and information about COVID-19 guidelines. While most patients called once or twice, we observed a small population with numerous telehealth visits. In fact, one patient even called 18 times over an 8-week period. These frequent utilizers of healthcare have been termed super users in the prior literature. While the emergency department super user has been the most well studied, super users of other fields, such as emergency medical services, radiology, and even trauma, have been studied. The importance of studying these super users is reflected by their disproportionate use of healthcare resources. As virtual care continues to grow, characterizing these telehealth super users will prove useful in addressing their specific needs. We compiled all the users that had at least one visit in our virtual care platform, Mount Sinai Now, between March 1st and April 30th of 2020. We identified users who had called over 5 times, and using our electronic medical record EPIC, we gathered basic demographic information, which can be seen in bottom left table 1. Super users tended to be young and female, which is grossly similar to the non-super user cohort. The distribution of ethnicity as well as insurance status can also be seen here. Overall, there were 5,604 patients who called in for 7,639 telehealth visits. The breakdown of patients versus visit proportion is seen in Figure 1. There were 75 users who called over 5 times, accounting for 496 separate visits, or 1.34% of the total patients, accounting for 6.5% of total visits. By combing through the EMR as well as provider notes, we were able to identify their past medical history, as well as their reason for initiating each telehealth visit. Telehealth superusers tended to be relatively healthy. 35% had no medical problems, 37% had one medical problem, 23% with two, and 5% with 3 or more medical problems. The most common medical problems were psychiatric, followed by asthma, then hypertension. Super users' visits' chief complaints were overwhelmingly related to COVID. As you can see in Table 2, 55% were attributable to viral symptoms such as URIs, lower respiratory symptoms, GI, and constitutional symptoms. 12.3% were for prolonged persistent symptoms, 11% were for asymptomatic COVID-related questions, and 13% were due to anxiety and stress about the pandemic and lockdown. Repeat non-COVID related visits tended to cluster around a specific complaint, such as back pain. Using timestamp data from Mount Sinai Now, we were able to look at the distribution of repeat visits seen in Figure 2. We saw that 28% of repeat visits were within 24 hours of a prior visit, and most, or 60%, of the visits were within 72 hours of a prior telehealth visit. Only 13% of repeat visits were after 1 week of a prior visit. From our electronic medical record, we saw that 25% of patients ended up visiting an ED at some point, and 16% to an urgent care. Of the 75 super users, only 2 patients had ever used our Mount Sinai Now service before, and 60% had actually never been seen in our Mount Sinai system at all. 48% of these patients continued to use our telehealth service after April 2020. In a pandemic like COVID-19, virtual care can provide patients with safe, convenient, and individualized medical advice while also reducing the in-person risk of virus transmission and PPE consumption. With the influx of new virtual care patients, super users were observed. Like super users of other medical specialties, virtual care super users merit study to better understand and address their needs. The preponderance of psychiatric comorbidities suggests a specific need for mental health options to be included with virtual care services like ours. The timing of repeat visits is also another area of interest to evaluate why they call back so soon after a prior visit. Further research is also needed to elucidate any meaningful differences between the super user cohort and the non-super user cohort.
Hi everyone, my name is Kiana Zahiri, and I'll be presenting my research about voting during COVID-19, emergency absentee procedures for hospitalized patient voting and statewide election process changes. As we all know, the COVID-19 pandemic has drastically impacted virtually all aspects of our lives. Due to social distancing guidelines and risk of viral transmission, the pandemic has posed a significant challenge to upholding the major 2020 elections while also protecting public health and avoiding infections and superspreader events at voting polls. Previous research studies have found that hospitalized patients in the U.S. and those facing severe illness, particularly those that are from marginalized populations, are vastly underrepresented in voter turnout. A number of states have emergency absentee voting procedures that allow voters to obtain and submit absentee applications and ballots if they experience a medical emergency or are hospitalized after their state's regular absentee deadline. However, these guidelines and restrictions vary greatly between states. In our study, we aim to identify state-by-state emergency absentee voting procedures as well as COVID-19 related changes to these procedures. We assessed 34 variables, including methods and deadlines for obtaining and submitting voting applications and ballots and the various requirements. Data was collected from State Board of Election websites, poll worker manuals, application forms, and state legislation. Data relating to COVID-19 related election process changes were recollected weekly to account for any updates. Following this, data was verified through direct correspondences via phone or email with the Board of Elections of all 50 states, and Washington, D.C. was not included in this analysis due to non-response from its Board of Elections. As you can see from our maps, we found that 39 states have emergency absentee voting processes, 5 states are universal vote by mail, and 6 states have extended regular absentee voting deadlines. Unique aspects of emergency voting processes that we identified included patients designating an authorized agent to deliver their applications and ballots, which was an option in 38 states, electronic ballot delivery, which was allowed in 5 states, or in-person teams that deliver ballots directly to patients, which is present in 18 states. We also found that 23 states had legislation extending emergency absentee voting privileges to family members of hospitalized patients. 17 states had such legislation for healthcare workers who are unable to vote in person due to occupational duties. However, there are a number of barriers that were identified in these processes nationwide, such as lack of transparent information online for 11 states, 7 states had restrictions mandating agents to be family members, physician affidavit requirements in 8 states, and notary or witness signature requirements for 15 states. For COVID-19 related changes, 20 states delayed state-level elections, and for the presidential election, only 10 states expanded absentee eligibility to allow for COVID-19 as a reason to request an absentee ballot, and 15 states mailed absentee ballot applications or ballots to all registered voters. Due to infection control-minded restrictions, some states also canceled in-person ballot requests, or canceled and decreased number of in-person delivery teams. However, 3 states, Arizona, Rhode Island, and Tennessee, adapted to these restrictions by allowing for healthcare workers and ballot delivery teams. Although there are many existing structures that allow for emergency absentee voting and a number of changes were made in light of COVID-19, there was still a number of barriers making voting challenging for hospitalized patients, so there's considerable room for improvement from a policy standpoint. Knowledge of such information regarding emergency absentee voting processes is vital among healthcare workers and patients alike to allow for equitable access to civic participation for all. It is important to raise awareness of these processes and barriers that patients face with voting within the medical community to continue advocating for increased accessibility to voting for our patients.
Hi, my name is Kirlos Haroun, and with the support of my fellow authors, George Musa and Dr. Eugenia South, I would like to talk to you today about the opioid epidemic and urban park use's effects on mental well-being, stress, and anxiety. We do not have any relevant financial or non-financial relationships to disclose. The U.S. Department of Health and Human Services reports that up to 1 in 8 ED visits is related to mental disease or substance use, with that proportion increasing every year. Outside of the ED, the opioid epidemic has only worsened this trend, unfolding in a very public manner in parks and under bridges. Inequities in access to safe outdoor spaces exists in low-resource communities, and time spent in urban green spaces is known to prevent and mitigate stress, anxiety, and depression. Overall, little is known about how green spaces in low-resource neighborhoods struggling with the opioid crisis may impact the mental health of nearby residents. Our objective was to investigate if the Philadelphia urban park's lack of safety and accessibility would have detrimental effects on the local residents' stress, anxiety, and overall mental well-being. We performed a cross-sectional survey of 36 residents within a 3-block radius of an urban green space in a Philadelphia neighborhood that experiences the highest rate of opioid overdose and death in the city. To do this, we used a door-to-door consecutive sampling methodology. Our survey questions included open-ended perceptions of the park, as well as the WHO Wellbeing Index, or the WHO-5, the Perceived Stress Scale 10, or the PSS-10, and the Generalized Anxiety Disorder 7, or the GAD-7. Quantitative data was analyzed with linear regression models and ANOVA tests. For the qualitative data, a content analysis approach was used. The majority of participants were female, Hispanic or Latino, and long-time residents, with a mean of participants living there 14 and a half years. They visited the park on average 3.7 times in the prior 2 weeks. Over half of participants perceived the park to be rarely to never safe, but that did not significantly correlate with the amount that participants visited the park. The perception of park safety positively correlated with WHO-5 scores, as you can see in the chart, and negatively correlated with PSS-10 scores, as can be seen in the second one. Participants' PSS-10 increased on average by 0.22 points for every year of residence. And overall, qualitatively, the top 3 reasons for avoiding the park included needles, drug users, and violence. The conclusion that we took from this was that the perception of an unsafe urban green space in the heart of a neighborhood impacted by the opioid crisis was associated with increased levels of stress among longtime residents. Understanding the social context in which our patients suffer worsening mental health is key to stemming the growing tide of mental illness and EDs nationwide. Emergency rooms overwhelmed by the opioid epidemic and the overall burden of mental health can possibly direct advocacy efforts to maintain local urban green spaces as key components of a community's mental well-being. Thank you for listening, and thank you for being here.
Hi, everyone. Thank you so much for joining this talk today. My name is Kenneth Lee. I'm a 4th-year medical student at Northwestern University in Chicago, and I'm really excited to represent a group of us working to address homelessness here at Northwestern. To start us off with some background, individuals experiencing unstable housing often have a very complex mix of unmet medical, social, and personal needs that are often correlated with issues such as mental illness, substance use, and early mortality. Here at Northwestern, we do serve a very high volume of patients experiencing unstable housing, and because of that, have set a long-term goal to better serve the needs of these patients. That said, when we started to think about this work, we realized we were having a hard time figuring out who these patients were, let alone understanding the deficiencies in their care. So we started to ask ourselves, how do you build an intervention for a population when you're not even sure who's included in that group? So we decided to try to figure out a way to identify this population within our own system. And the first objective became building this initial methodology to query our EMR and to quantify the number of patients that resulted from that search. In addition, we wanted to conduct manual chart review on this group to both verify the validity of our search as well as to identify any other areas of the patient chart that were not originally a part of our search criteria that we may have originally missed out on. In order to accomplish both of these goals, the Northwestern Enterprise Data Warehouse was searched to identify patients experiencing unstable housing that presented as either an ED visit or an inpatient admission from March of 2018 to July of 2020. The specific criteria used included searching for keywords such as undomiciled or homelessness within 4 specific domains, which are listed here. We also searched for any patient tagged with ICD-10 code Z59. Of these charts, a small number were randomly assigned among 5 clinicians who manually reviewed charts with 2 objectives in mind. The first was to confirm that documentation existed in any of the 4 criteria that we set, and to also look for documentation in any other parts of the chart as well. So the initial search yielded about 5,600 patient charts, and among the 48 randomly selected for chart review, 7, accounting for about 15%, ended up being false positives, so they were not found to have any documentation related to unstable housing. Among the 4 initial criteria we set, documentation regarding housing status was found most frequently within patient address, which notably was positive in just 39% of cases. Other parts of the chart found to contain documentation included largely unstructured data sources, such as narrative notes by physicians and nursing staff and social work and many other providers. We do recognize that there were several limitations in our study, and to highlight a couple, our inability to mine unstructured data likely limited the effectiveness of our identification process. And another major limitation for us was that we had a fairly limited sample size for manual chart review. We ended up being able to review just less than 1% of the overall sample. Despite those limitations, however, we do think there are a couple conclusions to draw from this. One was that there was no single consistent, reliable method for identifying patients experiencing unstable housing in our EMR, as documentation was extremely fragmented across so many different locations within each patient's chart. The other conclusion for us was that though our initial methodology is promising, it does likely miss out on many patients because we're not currently able to search unstructured data. This segues us right into the next steps in mind, which include big picture, just iterating on our methodology. And we have a couple big priorities for this. One is to hopefully incorporate technology such as natural language processing to be able to query unstructured data. We think this will allow us to capture many more patients than we are currently. The other big priority for us is to improve the accuracy of our search and to reduce the frequency of false positives. We hope to accomplish this as we expand the numbers for manual chart review and better understand what exactly is driving those inaccuracies. With that all said, thank you so much for your attention and time today. Please do feel free to reach out if you do have any questions. Take care and please enjoy the rest of the conference.
Good morning. My name is Emmy Wabweze. I'm a third-year resident at the York Hospital Emergency Medicine Program in York, Pennsylvania. Today, I will be discussing my research study that took place last year. It's entitled Use of Rideshare Services for Patient Transport to the Emergency Department. This study, I would say the main aim for the study or goal was to discuss how rideshare impacted access to the emergency room, specifically at our hospital. We noticed that more and more people are using Uber and Lyft to access the emergency department. So we wanted to know what factors played a role primarily, and then how did these factors compare to those factors that, to those of taxi or bus, for those that use taxi or buses. This research took place at a large tertiary care center in Central PA, that would be York Hospital. This was a survey-based study, prospective study. We used surveys to collect our information. We had our ED clerks collect the information or collect the surveys from patients. This specifically took place between February of last year to September 2020. We did exclude patients who either used private vehicle or used an ambulance to access the emergency department. If you were not an English or Spanish speaker, unfortunately, those patients were excluded. And of course, if patients refused to use or answer survey questions, we also had to exclude those patients. Our surveys consisted of 11 multiple choice questions. It was mostly multiple choice, but there were some open-ended aspects of the surveys. Our data was then analyzed using chi-square, independent t-tests, and Mann-Whitney U-T testing. Transport factors, for the most part, we found that most patients that use rideshare used so because they did not have form of transportation. The second most common cited use or noted use by patients was lower costs. And then some patients noted that just thought it would be faster to get to the emergency department rather than using an ambulance. And then other things that we chose to objectively look at: cost, timing, distance, arrival time, all of those things. Between the two groups, we noted, if you can look at the p-values, that there were not significant differences between Uber and Lyft versus taxi and bus. And then sort of less subjectively, we asked about illness severity. Patients seem to be in the Uber Lyft group, seem to see their illness severity or acuity as maybe more acute or more severe compared with the taxi bus group. However, again, if you look at the p-value, these things were not significant. We were able to conclude that rideshare use, for the most part, patients cited that it was lack of personal transport, essentially not having a car, that influenced their use of rideshare, duration of trip, costs. However, if you look between Uber and Lyft groups versus taxi and bus users, there weren't really a significant difference between the two. Our major limitation was sample size, data collection, all of those things majorly impacted by the COVID-19 pandemic. And I'd like to thank Dr. Dosty, who is the principal investigator. Huge thanks to Dr. Becker, who is our director of our research department at York Hospital. He, along with Barbara Stallman, played a critical role in data analysis, so I'd like to thank them as well. I will take any questions that you may have.
Hello, my name is Daniela Fazio. I am a clinical research coordinator at NYU Langone Health. Today I'm going to be talking about a study, Targeted Homelessness Prevention Intervention for 80 patients with unhealthy alcohol or drug use, a pilot feasibility study. This research was led by Dr. Kelly Doran at NYU Langone Health, along with collaborators from the New York City Human Resources Administration. This study was funded by a NIH NIDA K-23 grant and the Doris Duke Charitable Trust. The purpose of this study was to test the feasibility and acceptability of implementing a homelessness prevention intervention for emergency department patients with unhealthy alcohol or drug use who are at risk for homelessness. We randomly screened patients at Bellevue Hospital's Adult Emergency Department in New York City, and to be eligible for the study, patients were 18 years and older, medically stable, not incarcerated, spoke English, and had a phone where they could be reached, whether that be their own phone or someone else's phone. To be eligible for the study, patients also had to screen positive for unhealthy alcohol or drug use using a previously validated single item screening question. Unhealthy alcohol use was essentially any binge drinking in the past year, and drug use was any drug use in the past year. Additionally, patients who are eligible for the study were not currently homeless, but screened positive for risk of homelessness using a homelessness risk screening tool. The 3-item homelessness risk screening tool that we use was developed in Dr. Kelly Doran's past research and identifies patients who are at risk for shelter entry in the next 12 months. We enrolled 40 patients, and 1 patient later withdrew from the study. Of the 39 participants, 77% were male, 46% were Hispanic or Latino, and 49% were Black or African American. While participants were still patients in the emergency department, they completed baseline verbally administered surveys and received a 3-part study intervention. First, we referred participants to an existing ED substance use program called ED Leads at Bellevue Hospital. The program's team of social workers and peer navigators provided patients with substance use screening, brief counseling, and referrals to substance use treatment if necessary. Second, participants were referred to Homebase, which is an evidence-based community homelessness prevention program in New York City. Study staff provided participants with printed directions to their local Homebase office, as well as a round-trip Metro card to get to and from the Homebase office. Study staff securely emailed a referral form containing the participant's name and the level of housing risk to each participant's local Homebase office. Third, study staff followed up with participants over the phone up to 3 times, 7 to 10 days after their baseline visits, to assist participants with access to Homebase. On to the results. 32 participants attended a 6-month follow-up visit and completed follow-up verbally administered surveys. 72% of those participants said it was very or extremely helpful talking about housing at baseline. 66% said it was very or extremely helpful getting help with substance use at baseline, and 97% were satisfied with their overall study experience. 63% of participants need contact with Homebase, either over the phone or in person, and of those who were in contact with Homebase, 50% reported that the Homebase services were helpful. 41% of participants said that their housing situation improved in the past 6 months, and 50% said that their housing situation had not changed in the past 6 months. At the 6-month follow-up visit, we asked participants about different ways in which we could improve the study for a future trial. For instance, we showed participants a 3.5-minute existing Homebase informational video about a woman who successfully connected to Homebase services. 60% of participants said that they would have been more likely to go to Homebase if they saw the video when we first met with them at baseline. One of my favorite parts about conducting the surveys for this study was getting to hear the many positive comments about participants' study experiences, as well as their satisfaction with the services that they received. One participant said, "I like this study. What you are doing is good. You are helping a lot of people. You got me to Homebase, you did it." It was also inspiring to hear participants' suggestions about how we can improve the study for the future and how they think we can best help future emergency department patients. This was just a small pilot feasibility study, and our study was not powered to test effects of the intervention on housing or substance use outcomes. However, our team will be applying for grants to conduct a larger trial in the future. Thank you.